Hi everyone, my name is Mr. Paul Trikha. I'm a consultant knee surgeon. I only focus on the knee and I look after all patients from the very young with sporting injuries to the elderly patient with a worn out knee. My main focus is to try and save the knee at all times. So degeneration and knee replacements is the very last resort, and we always try and do the minimum but most effective treatment, be it surgical or non-surgical, to keep the knee and get people returning back to their normal function. In the NHS, I work at Ashford and St Peter's NHS Foundation Trust, where I'm the clinical governance lead. In the private sector, I'm a partner at Surrey Orthopaedic Clinic and the lead knee surgeon there, and one of the knee surgeons also at Showen Clinic in London. So when you injure your knee and there's acute swelling, we need to rule out 4 or 5 key things. The first and the most important thing is there a fracture, or have you torn the tendon at the front of the knee called the quads tendon or the patella tendon? And this is often a sudden explosive motion and you can't walk. Okay, and for that injury, a fracture or a patella extensor tendon rupture or a quads tendon injury, patients normally go to A&E and can't lift their leg up straight, and they often can't walk. That's the first thing, so exclude a fracture. The second major thing is, has the patient, or have you had a major ligament injury? If you've had a major ligament injury, an ACL, anterior cruciate ligament injury, many footballers or skiers do, they have a pivoting injury, often non-contact twisting injury on the pitch or on the ski slopes, are unable to continue. They may or may not hear a pop, but they get acute swelling, and that often settles down after a week or 10 days, and then the patients feel better, but that acute non-contact twisting injury, be it on a ski slope or on a pitch or a skateboarder, and they are unable to continue, often signifies a ligament injury, and the ligament we're most aware of is the anterior cruciate ligament, or the ACL. The third is the meniscus. The meniscus is the cartilage in the knee, and on this model, it's the blue structure. It's the cushions between the thigh bone and the shin bone, the cushions between the femur and the tibia. You have one on the inside, the medial meniscus, and one on the outside, the lateral meniscus. Now, if these tear and you've had an injury, we should repair them, not remove them. We should repair them. These are your cushions, your shock absorbers. And when these cushions are gone, be it surgically or are ripped, i.e. they've been removed, you lose the cushions and you can get bone on bone rubbing, and that is arthritis. That's what happens with time. So saving the meniscus is one of the key things I'll talk about today, but that is the third injury. And this is very important. Meniscal injuries are very different in the person who injures their knee, the young patient playing sports, or the young woman who stumbles in high heels on a curb and falls over. Those need to be repaired, traumatic injuries. But the cartilage injury as you get older, in your 40s and 50s and 60s, that just wear out slowly, they don't need surgery. They often do very well. It's like if you get wrinkles or grey hair, you might have these meniscal tears with age. So that's the important thing for meniscus. The fourth thing, in the younger patient in particular, is a kneecap dislocation. So, traumatic injury to the knee, the kneecap pops to the side and comes back. Sometimes the ambulance or the hospital need to pop it back. Commoner in young patients, but can go on into your 20s and beyond. And normally the treatment for kneecap dislocation is to strengthen the muscles around the knee with lots of physiotherapy. And if the kneecap keeps popping out, then we can do some surgical options to stabilize the kneecap. So in summary, if you injure your knee, you want to exclude a fracture, you want to exclude a major ligament or anterior cruciate ligament injury, a traumatic cartilage or meniscal injury, and a kneecap dislocation. The other rare thing with with an injured knee or a non-injured knee is if the knee fills with blood. Some people take blood thinners like warfarin or injections for blood thinners for other medical problems, and that can cause acute swelling And sometimes you have to ask the patients, are you taking any blood thinners, particularly if they've had a minor injury? So let's go back to those. If you fracture or injure your extensor mechanism, so a quads tendon, patella tendon, or a fracture in the patella, it means you cannot lift your leg straight in the air. If you cannot lift your leg straight in the air, you have injured one of those things. You need to go to hospital. If you fracture the shin bone or the femur, then you probably can't take a step. So again, you need to go to hospital. So the first thing, have you had a fracture? You need an x-ray. You need to be examined. Pain, swelling, they're the major symptoms. The second major cause is a ligament. The anterior cruciate ligament is the major ligament in the middle of the knee. This one here. It stops the knee being unstable when you twist. So people with ligament injuries in the knee often complain of instability, giving way. And those that complain of recurrent instability, if your knee keeps giving way, you are going to damage the third structure, the meniscus. And we've already talked about how important the meniscus is. If you damage your meniscus and you have a big tear, the knee can jam as it tries to extend on the meniscus. Okay, and that's locking. The patient says, oh, as I try and stand up, my knee locks or jams. Okay, and when it does that, your knee wants to give way as well. So far we've got pain, inability to weight bear, inability to straight leg raise, recurrent giving way of the knee, locking. And then the fourth common condition was the patellofemoral dislocation. And obviously patients know that their kneecap has popped out, they're a little bit stuck, and the only way they can get the kneecap back in is either manually pushing it back in or straightening the knee out and the kneecap pops in. They're the major symptoms to look at. Okay, so what do you do when you injure your knee? Most important, can you walk? Can you stand? Can you take weight? If you can't, you need to go to hospital because you want to rule out a fracture with an x-ray. The second, can you straight leg raise? Can you lift your leg? I'm going to try and get it on camera, in the air against gravity. If you can't do that, then you may have torn the patella, fractured it, or the quads tendon, or the patella tendon. If you look at this thing, if you take the patella tendon off, the leg will not be able to lift the tibia, the shin bone, in the air. Okay? This bone, the femur, is connected to the shin bone by this tendon mechanism, the kneecap. If your knee recurrently gives way, you cannot trust the knee, then that is another serious sign. And if your knee locks or jams, then this is serious, because if you're on a ladder or on stairs and your knee jams, then you may have a problem. The other obvious feature is recurrent swelling. So when your knee swells acutely after an injury, you have to rule out those things we just discussed. Okay, so if you've injured your knee, what do you want to do? You want to protect the knee. Think of Price. It used to be Rice, but Price. Protect, either with a support or a bandage. You want to rest, ice, compression of some kind, either a tubercular bandage, and elevate. You respect your knee when it's full of blood, i.e. it's injured. Okay. With time, the treatment options vary. So obviously with a fracture or an extensor mechanism rupture, these might need repairing or fixing to stabilize the leg. With a ligament injury and you're having recurrent instability and you do a lot of sports, you might have surgery. Okay, but physiotherapy is very useful for people who don't do pivoting sports and they don't have giving way. What about big meniscal tears? So traumatic meniscal tears are often repaired to try and protect the meniscus, because you don't want to lose your meniscus. Not so long ago, people were having keyhole surgeries a lot to have meniscus removed, and we don't do that routinely anymore for degenerative, worn-out tears. So if you have a degenerative tear, you've got a bit of catching in your knee, the knee is manageable, but occasionally it comes and goes, the pain can come and go or wax and wane, then physiotherapy, which is one of the first lines of treatment for many of these conditions, is a very good, valid option. Especially on the last one, for patellar dislocation, The treatment normally for first-time dislocators, where there's no bony injury, is to stabilize the knee with lots of muscle work, lots of exercises, lots of physiotherapy. So when you've got a big injury and there's blood in the knee, you might want to go and see an expert to make sure you can clearly diagnose which one of those problems you have, then start physiotherapy and see if you have ongoing symptoms, and then consider surgery as required. Okay, so if we take the three commonest things that I will see in a knee clinic, not on an acute clinic where the fractures are often treated and fixed, are anterior cruciate ligament. So anterior cruciate ligament gives you stability, and the indication for surgery is instability. And there are a number of structures we can use to recreate this anterior cruciate ligament. We take a graft either from the hamstring tendons or the patella tendon or even a quads tendon, and we place a new graft inside the knee. The surgery typically takes about an hour, depending on what else we need to do in the knee, and repair meniscus perhaps. But the rehab is significant because you have to rehab and strengthen your knee to allow time for this ligament to heal, the new ligament, and also to allow time for your muscles to regain strength. And this can take anywhere from 7, 8, 9 months to up to 18 months, depending on the patient and the amount of exercise and other surgeries that will perform. So the major one is ACL, and typically for our athlete patients, it's at least 1 season out, and the rehab is significant. So if you're not prepared to do the rehabilitation and the exercises, anterior cruciate ligament or posterior cruciate ligament, surgery maybe isn't best for you. The commonest surgery we used to do was for the third condition, meniscal tears. As I said, not so long ago, we did trim the torn bit. Now we try and save or repair the meniscus wherever possible, because losing the meniscus does cause arthritis, particularly in the lateral outside compartment of the knee. If you have a meniscal repair with sutures, you might go in a knee brace for up to 3 months to protect the repair. That's how important the meniscus is. If you just had a tear which is caught or jamming and we remove a small bit, that recovery is very quick. You might be back at work in a few days' time after surgery. As I said, we do that surgery less, but sometimes you can have a trapped piece of meniscus and you fish that piece out, and it's a very quick and straightforward surgery with instant relief. So the more we reconstruct or repair, you have to rehabilitate your knee. If we're removing a small part, the surgery is fairly quick. And all the surgeries I mentioned are keyhole procedures, minimally invasive, small scars. The fourth condition is physiotherapy, patellofemoral dislocation, and there are a number of smaller procedures where we can recreate ligaments here to stop the kneecap popping out, to making new grooves in the opposite side of the patella called the trochlea, and that surgery is quite big. And also, if the kneecap is high, we can lower the kneecap, called distalization, by removing this and moving this bone around as well. But as I said, most of these conditions will do well. Surgery in a few when needed for the right indications, but physiotherapy and getting people active again is what we're trying to do. Okay, so when you injure your knee and you want to exercise, a lot of people, when can I exercise? Okay, and the rule of thumb we say is when the knee is quiet and calm and you can wait there. It takes a few weeks after the injury. And then you might focus on low impact exercises. Low impact are when your body weight is not on the knee. So if you go to the gym, you might not do weighted squats, you might do bench squats. If you go to the gym, you might just sit on a bike so the body weight's not going through the knee. And in fact, bike is a very positive exercise for all knee injuries. The third one is swimming in the pool. Again, not all your body weight is going through the knee. So any low impact exercise, but particularly cycle, is very good for those desperate to exercise when they're injured.